Hi, my name is Shawanda Martin, and I am a master's level social worker. I've been in the behavioral health field for about 14 years now. I'm an independent consultant, and I also work with MHR agencies. And let's get right into our presentation for today. Okay. So this presentation is about building efficient billing systems in your EHR for clinical staff. Why billing, why billing efficiency matters. Accurate billing ensures timely reimbursement, financial stability. It reduces administrative burdens on clinicians and staff. It decreases claim denials by improving front-end data capture, and it also improves patient satisfaction through clear statements. When it comes to accurate billing is the foundation of any agency's financial health. Um, when claims are submitted correctly with accurate service codes, units, dates, provider credentials, authorizations, and compliant documentations, payments are processed faster and without unnecessary delays. When you have accurate billing, the timely reimbursement supports your payroll for clinical and support staff, program sustainability and expansion, technology, training, compliance infrastructure, and continued access to care for your clients. Inaccurate billing can result in delayed payments, denied claims, recoupments, even payer audits. Over time, repeated billing errors place the agency at a financial risk, and it can jeopardize services as well. Accurate billing protects revenue already earned and ensures long-term organization stability. So the bottom line here is when billing is accurate, the agency gets paid correctly and on time for the services it provides. The second part of this is the reduces of administrative burden on clinical staff. We know that sometimes when we send our staff back their notes or their logs or what have you, they feel frustrated. It's like I've been did this. Why are you just sending this back? So when documentation and billing information are inaccurate or incomplete, the administrative burden increases on not only you, but your billing staff, the owners, the agency as a whole. The burden increases on everybody involved. Clinicians may be asked to correct their notes and missing information or respond to billing inquiries weeks after a session has occurred. This creates frustration. It takes away from client care and contributes to burnout. Accurate documentation and billing reduces repeated follow-ups for billing and compliance teams, note addendums, late corrections, email chains, phone calls, and interruptions to their day-to-day staff frustration and insufficiency. Um, Standardized documentation practice is a key to ensuring that billing efficiency matters, such as structured templates, clear workflows, real-time documentation, allowing clinicians to complete notes correctly the first time. This results in smoother operations across your clinical billing and your administrative teams. So clean documentation up front saves time, reduces stress, and allows staff to focus on their primary roles. It decreases claim denials by improving front end data capture. And the majority of our claim denials originate at the front end of the process, not during billing submission. And so I think a lot of times we get that confused as to, oh, I don't know why this denied. Well, you have to start at the head, and that's when your staff is putting these notes, claims in. Errors such as incorrect demographics, missing authorizations, invalid service codes, mismatched units, or incomplete documentation often leads to denials that could have been avoided. So you want to always make sure that your front end is strong, where it includes accurate demographics for your patient information. Make sure that you have valid authorizations, correct CPT codes that's in your EHR systems, proper provider credentials that's servicing these clients, as well as the locations. Documentation that clearly supports medical necessity. Fewer denials mean fewer appeals, faster payments, and reduced administrative costs. Improved front end accuracy also strengthens compliance and audit readiness. So the bottom line here is most denials are preventable when information is captured correctly from the start. When it comes to improving satisfaction through clear statements, and this is billing accuracy directly impacts the patient experience. When claims are billed incorrectly, patients may receive confusing statements, unexpected balances, or bills for services they don't understand. And this goes for Medicare, Medicaid, private pay clients. Those, if you this can damage the trust that you have within your client. This can damage the trust and create unnecessary stress for the clients and families. Accurate billing leads to clear and understandable patient statements. Fewer billing questions and disputes reduces financial stress for clients and increased trust in agencies' professionalism. So accurate billing is not just a financial function, it is a shared responsibility that supports the organization's sustainability, staff efficiency, the compliance, and patient trust. When documentation and billing are done correctly the first time, everyone, everyone benefits. So when we get over to streamlining clinical documentation for billing, we want to emphasize documenting at the point of care to improve coding accuracy. Use structured templates, smart phrases, and checklists to ensure all billable elements are captured. Encourage staff to understand which documentation elements impact coding, and leverage clinical decision support to prompt missing required documentation. And what the point of care to improve coding accuracy, what that means is the point of care documentation equals writing your notes during visits or immediately after while the details are still fresh. Because sometimes memory fades fast. And if you're like me, your memory fades really quickly. Sometimes if it's not written down, I don't really remember it. And sometimes that happens with our clinicians as well. So if our clinician waits to the end of the day or later in the week, they may forget exact time that they spent there, like their start time is very important. Specific interventions that they used, clients' response in their progress, and the risk factors addressed, whether it's suicidal, homicidal, safety, or there any crisis issues. Those all play a part into the memory fading fast. And then the second part of that is coding depends on details. And so many payers require elements to justify their code or the units billed. And so each payer is are all differently, but the time needs to be clear. Just like I just said, the start and stop time or the total time. So you want to get in the habit of getting your staff, your clinicians to put exact times, because we all go into meetings or we have sessions or whatever it may be. Like, we don't do everything on the hour. And so we want to make sure that they're documenting actual times. So if they get there at 12:05 for a session and they don't leave until 1:33, those are the times that they need to put, because guess what? That's what the payers are looking for real life scenarios, real life things. And that time is real life. So you know that every day you're not going to clock into your job at exactly 9 o'clock. You're not clocking out for lunch at exactly 12 o'clock, and you're not clocking out to go home at exactly 5 o'clock. So you want to make sure that we give our staff is doing the best practice, and we want to make sure that they're putting those real time, because real-time documentation equals fewer addendums. When notes are completed and accurate the first time, billing doesn't have to chase clinician down for clarification or, hey, your logs are incomplete or whatever the case may be. That means claims go out faster and you as an agency gets paid faster. In training, one thing that you can tell your staff is, if we don't document what we actually did, when we did it, and how the client responded, our billing is guessing. And guess what? Payers don't want to guess. So that's one thing. And then the next, in this slide is use structural templates, smart phrases, and checklists to ensure all billable elements are captured. And here we want to use pre-built note formats, which require fields. And in Checkpoint, they have that. So when you hit that plus sign, you already have fields that's already a structured template already there. All you basically are doing is you need to put whether you're doing a telehealth, in person, or what have you, they're in there for those. If you have checklists for your staff, checklist prompts when the notes or a separate form that remind clinicians about required elements. So if you're doing a burp note and you give your staff all the acronyms for the burp, what should be in the note, what each one of them stands, then they can go by that, use a checklist, and that checklist helps them to ensure that everything is in there. And why does the structured templates, the smart phrases to checklists, why is this very helpful? It ensures billing elements are present, reduces variations between the clinicians, because if everyone documents differently, it's harder for billing to find what they need and easier for payers to deny. So standardization equals fewer gray areas for auditors and reviewers. It saves time and it reduces burnout. Clinicians don't have to reinvent the wheel for every note. Smart phrases can cover common interventions, safety checks, client engagement and participation. And it also can improve your compliance and the readiness. Templates can be built to mirror payer and regulatory requirements, so each note naturally checks those boxes. So this is very, very important to have checklists for them when they're doing their notes. Moving on to the next one, encouraging staff to understand what documentation elements impact coding. And when you help staff, because clinicians don't need to be coders, but they do need to understand what parts of their note affect what can be billed. So again, everything in billing is like a repeated thing. You'll hear it several times throughout billing. Time is one of the most important things when it comes to billing. Many services are building units, and so 15-minute units. Great. So if time is missing, unclear, or doesn't support the unit's bill, claims can be denied or recouped. So you also have to make sure that if your staff is billing a 1.5 note or a 2-hour note, that those times have to be justified of why they're billing those times. Notes should clearly reflect the start and stop times or total time spent, service types and complexity. The note must match the service bill, PSR versus CPST, therapy versus IOP group. The interventions documented should fit the service. if it's skill building, if it's intensive coordination, crisis intervention. If the note looks like a casual conversation or a case management, but the code is something more intensive, the payer are going to question. They're going to want that money back. And even in their notes, medical decision making, even in behavioral health, payers want to see your clinical reason. What symptoms or behaviors were was present? What risk factors did you assess? How did you decide on the interventions? Documenting these supports why the service was medically necessary that day. And think about it. If you think of your note as a story, that explains why the service on this day for the client was necessary and billable, the better your story, the stronger your coding. And then the last part of this slide, leverage clinical decision support to prompt missing requirement documentation. Every EHR system has pop-up alerts, and Checkpoint has a great system. It pops up, it has alerts where it alerts you when your authorization is getting ready to expire. This is something where you need to teach your staff where to go look, and even when they go into the client chart, how to see what or how many units are left for the authorization. This will help with denials, because if you're not checking your EHR system for these pop-up or alerts, of course, you will have denials after denials after denials if you have no one monitoring your authorizations. If you have if the diagnosis, Checkpoint is very good about that. If you put in a diagnosis for a client and that diagnosis is no longer a good diagnosis that's being used, it will flag it for you, and you can go in and fix it, and you can avoid these denials by just reading those alerts that's in your EHR system, whether it's Checkpoint or any other EHR system. If you check those alerts daily, get in the habit of first thing in the morning, let's check these alerts what we have. You can beat the system before the billing goes out to get those things corrected, so you can eliminate those denials. Yeah, okay. Using EHR tools to improve charge capture. And this is more so of the things, like I said, um, that are built in there. Most EHRs are designed so that once the clinician documents correctly, the system does all the heavy lifting for the billing. The key pieces like these are the summarization of the time, the location, the provider, the tools like the diagnosis, those things, the duration of the time, provider time, the location. Using these tools consistently means you capture every billing service accurately without relying on memory or manual coding. That increases revenue and reduces compliance risk. So if you use the tools that's already built into your EHR system, those tools are very, very helpful. And you have to take the time to really learn your EHR systems, because they have these tools that's built in there for you to have less denials. Highlight the importance of selecting correct visit types, orders, and procedures. Again, here it goes again, where you have to make sure that you provide those things, because the way an encounter is set up at the beginning, it drives everything that happens downstream from there. So visit type control rules, order of procedure must match what you actually did, and the impact on authorization and limits. When the visit types and procedures are correct, the system can apply the right code, check the right authorizations, and route the claims cleanly, reducing denials, and you don't have to rework these things. Using alerts and flags within, again, in your EHR system are very good things. This is where your EHR system, you get rejected notifications in Checkpoint. It notifies you if claims have been rejected. So you have to make sure that things are put in place from the beginning. Like I know in Checkpoint, it'll reject it if the date of birth is wrong, if the Medicaid number is wrong. And these are the things that you want to make sure that you in the demographic part are done from, done from the start. This creates a tiered approach, more attention where needed, quick processing where lower the risk. Tracking is transparency within this system. If the provider haven't signed, the charge failed, like if the modifier is wrong, these things, you get these things inside your EHR system. You just have to take the time to go through your EHR system before you send out billing to make sure that these things are done. Implementing automatic billing flows, pushing charges and coders, like these things are all in your billing system to help you with that. And so our next one is reducing errors and claim denials. Here, before we can fix denials, we have to know why they're happening. Most denials come from small preventable mistakes, not from payers being difficult, but from us as business owners, billing coordinators, consultants, whatever your role may be in the agency. The denials start with us. Sometimes as owners, directors, etc., we get frustrated at the payers because it's like we're not getting paid this, and this, but we have to fix what's in-house first. And sometimes the typical things, always when you see a denial, you go back, things you need to make sure is correct was their information right? Well, in Checkpoint, I know like if you don't put the names like it's listed in the Medicaid system, in that system, sometimes those are the reasons why, excuse me, for denials is because your demographic doesn't look like the payer's demographic, and that is a problem. So you always want to make sure that your demographics is good. Make sure that your provider, the rendering provider MPI number. You'll have to check Gainwell for those of you that is in Louisiana. Those are the things when you're hiring people, make sure that you check their Gainwell to make sure that they're active in Gainwell. The MPI can be an issue for that, using the wrong CPT code, authorization and eligibility issues, real-time eligibility checks. When you in Checkpoint, when you send out claims and they're with one provider, Checkpoint usually sends back a rejection before it even goes to the payer to let you know that that subscriber no longer is with that particular provider. So you have to make sure that you're always checking their Medicaid, ensuring correct authorizations are in the system. Sometimes they come back differently than they initially went out, and that's absolutely fine. But you always need to check your authorizations because sometimes when they call you on the phone or via fax or something, sometimes they mail you a partial denial letter, and in that partial denial letter will tell you why, and then you're not always allowed what you initially requested. And so you have to make sure you read those authorization, those approvals thoroughly to make sure that you're eliminating one thing that can cause you a denial. And then the frontline accuracy, what it really means is front end, is everything that happens before or at the time of service, intake, the scheduling, the eligibility, authorizations, and the encounter setup. If we get this wrong, the claim is already in trouble before the clinician even writes the note. So sometimes it's not even our clinicians that is causing the denials. It's the office staff where we initially didn't put something in. So verify the active Medicaid for the MCO before the first appointment, and again monthly each after, so that way you'll always stay ahead. Because if between October and December there's always open enrollment, and so if you're not checking consistently, then that may be a reason why it's denied, of because of that reason, because you haven't checked their Medicaid and they changed to a new provider. Here, make sure that you have end dates. The staff services help eliminate overbilling. For example, so if a client's PSR authorization ended on 10/31, but the staff continued to do PSR in November without a renewal, all the November PSR claims are at risk. And so even your documentation, even if the documentation is perfect, like perfect, you have to make sure that those authorizations are approved for those data services. And in Checkpoint whatever EHR system that you're using, there's ways to make sure that your staff doesn't over bill for those services. So if your authorization ends on 10/31, there's a way in that Checkpoint system or whatever EHR system you're using to be able to put an end date so they don't overbill, in which that will help you eliminate some of the denials. Then you have consistent documentation prevents denials, and that is absolutely true. The note must tell a story. Your staff notes must tell a story. Why the service was needed, what was done, how the client responded, in a way that supports the code you build. Core documentation elements that affect payments. Medical necessity is one of the top things. They have to clearly describe symptoms, function impairments, like if it's that they have it at home, school, work, or community, and why this service level is appropriate. Link to the treatment plan, like the goals and objectives from the treatment plan should show in the progress note. If it's not on the progress note, if it's not on the treatment plan, then those goals and interventions shouldn't be used. Interventions should connect back to the goals that are on the treatment plan that they have. The time and intensity, again, here we go again with the start time, the stop time. That time is very, very important. Specific, not vague interventions, talking about my feelings. That is a weak. That is very vague and weak. You can go back and say, assisted client in identifying triggers for anger at school and practice 2 coping skills: deep breathing, walking away. That's a strong intervention. Excuse me. Client's response and progress. Document on how the client responded. Improve, resistant, required redirection, etc. This shows if the service is effective and why it should continue. And so timely signing of encounters prevent delays. You want to make sure that signing the documentation and stuff, it really, like, they get it signed, you review it. Denial reductions is a team sport. Clinicians, front desk, billers, the leadership all have roles. Staff need to understand that the impact of their work and to be held to clear expectations. Explain why. Explain the why. Show the clinicians how A bad note or a late note leads to denied or delayed payment for their work. Set standards. Example, notes completed in 24 to 48 hours, all fields completed, time documented on all sessions, provide feedback. Share examples of strong notes and problem notes. Use peer review or chart audits to give constructive feedback. And connect performance to outcomes. Example, like you had 10 notes missing time last month. 8 of those claims were denied. This X dollars delayed. Let's walk through a template so this doesn't happen again. Like, why does this matter? It's because when staff see that the documentation and the accuracy are a part of their professional role and not extra work, they're more likely to take ownership of it. And sometimes you have to be more open with your staff so they can understand what you have to go through when they do bad notes. Denials aren't just headaches, they're data. Like, you can use that as data. If you track them, you can see the patterns and fix the root cause. One category, group by category examples: authorization issues, eligibility, coding, documentation, timely filing. And this can really help you. You can use those of you who have CARF, Joint Commission. You can use these tools inside of Checkpoint or your EHR system. Excuse me. To help you with quality improvement. You may notice that denials for no authorization on file is the root cause. So staff don't see when authorizations are in, and well, we assume they don't see it, but in your EHR systems, you can go in there, show your staff where their authorization is so they can keep a track of their authorization. And the solution to this is implement an authorization tracking report. EHRs remind them of their expirations. Without tracking, you're always reacting to individual denials. With tracking, you're proactively improving the systems and reducing denials over time. And so the bigger picture of this reducing errors and claim denials is reducing errors and claim denials is really about getting the front end right: eligibility, authorizations, their demographic set up, documenting well, which is clear, timely, medically necessary notes that match the code, letting the EHR system help with alerts and safeguards, building a culture of ownership. Everyone understands their role, and using denial data to improve, not just fixing, but learning. Learning from those denials. So our next one is improving communication between clinicians and the billing team. You have to create feedback loops so billing codes teams can share common documentation issues. A feedback loop is a regular, predictable way for billing coding staff to tell clinicians what's going wrong with documentation, and for clinicians to ask questions back. Without this, each side works in a solo. Billing just fixes what they can, and then they send back what they can't, sends back what they can't. And clinicians feel blindsided it sometimes, or like you're picking on them. And I get that all the time. Like the staff be like, "Oh, you sent all my notes back and I don't have time to fix it," things like that. Yes, they get frustrated, but if you teach them on the front side of what they need to ensure that is in their documentation, it will eliminate the frustration. Many denials and delays are caused by the same 5 documentation errors over and over: missing time, unclear service type, no linkage to the treatment goals, and wrong provider codes selected. Those are the top 5 things, documentation errors that you're going to always see. If billing sees the patterns but never shares them, the problem keeps repeating, costing money and more morale. Like if your billing team isn't reporting these things, then you have a problem. You have to make sure that everybody is on the same page and communicating these things so you can get them fixed. Clinicians always need a safe space to say, I don't understand why this code would change, or what do I need to write for this to be billable. So you have to be able to engage with your staff to make sure that they're comfortable in coming and telling you that, hey, I don't understand this. What a strong feedback loop looks like. One, you can do a thing with a monthly report of your top 5 issues. Billing runs a quick review of denied and held claims. In Checkpoint, you can go to claims accounting report and you can run a report from that last month of, let's see what didn't get paid, what denials we have, what's incomplete. Do that billing report every month and you can see where your agency is. In other EHR systems, you can do the same thing. Make sure you have an EHR system where you're able to go in and run these reports and be able to see like where money is missing, where denials, what's the reasoning, and things like that. They list the top issues, top issue you're billing for the top issues report for that month. They list the top issues: missing the start times, the service documented but wrong, service documented but wrong code was selected, no medical necessity statement. This is shared in a small email staff meeting or even in your EHR dashboard. Some EHR systems have where you can, when your staff log in, they have notifications. For those who use Checkpoint, if you have the client portal, you can message your staff in that secure portal inside of there, and you can go back and forth, so they, when they log in, they see your message in that that particular portal. Or you can do a quick 15-minute, I call it HMO, high money opportunity review. And once a month, you can do this again once a month. You can join your billing if you have your clinical team or your billing team. However, just a 10-15 minute thing. And they walk you through 1 or 2 real identified note examples. Like, here's how the note was written, here's the code we use, but here's what the payer looks for. You can kind of do that. And it's just like a 15-minute review of over your claims, nothing nothing too extraneously or that'll take up a lot of your time. And so the practical tip: create a simple template for your meetings. Issues we're seeing, what payers expect, and how to fix it in your note. This makes feedback quick to read and easy to apply to your staff. And then secondly on here, use EHR messaging or tasking systems to clarify documentation system correctly. Like I just said, you can use that in there, and even when you're correcting notes, it's a message in their notes in Checkpoint. You can send them a message and it'll go back to them and they can see what they need to add or what your concerns are about their logs. EHR, again, use your EHR systems to the best of your abilities. EHR dashboard banners, the announcement section, messages that appear once a week when your clinicians log in, or sections in your EHR. If you can label it, some EHR systems are customizable. If you can do your billing corner or documentation tips, just somewhere where your staff isn't overwhelmed, you leave these tips to them so they can know with more effective billing. And the good thing about using your EHR system is, one, the benefits of it is your staff can't say, oh, I lost my message, I lost my messages, or I never saw the email So there's no lost messages in your EHR system, a fast turnaround on small issues, and better documentation trail. And then the last, offer brief coding tips, summaries, or monthly updates inside your EHR dashboard. Instead of overwhelming staff with long trainings, they forgot you gave these small things. Focus on tips. Again, use your dashboards in your EHR systems if you have them. Leveraging analytics and reporting. So show how to run reports and open encounters, pending charges, and denial trends. Regularly review productivity and reimbursement matrix tied to documentation quality, and use dashboards to track clinician specific patterns and areas for training. Here, open encounters equal sessions that were started but not fully documented, signed, and closed in the EHR. And this why this matter is because if the encounter isn't closed, billing can't submit the claim. Open encounters create a backlog, miss timely filing limits, and confusion about what's truly done versus still pending. In CPS, TPSR, IOP therapy, where notes are frequent, even a few open encounters per clinician quickly adds up to thousands of dollars of missed things that your agency is missing. How to use reports. Run a weekly open encounter report filtered by clinicians, their service type, the data service, have supervisors or office manager review who consistently leaves encounters open, or are there patterns. Create a standard expectation. All encounters must be signed and closed within 24 hours. This will also help you with billing, because sometimes you have those incompletes that sit there for weeks at a time, months at a time. And if you don't have anybody that's constantly reviewing your system, then you're missing out on thousands of dollars, and you're paying out to your workers, and then you can't figure out why you have to pay payroll so much, but you don't have that income that has come in. And so that causes the a issue as well. And then when you have those pending charges, like pending charges equal services that are documented but haven't moved all the way through to a claim. Is it stuck in coding review? Is it missing data? Or is it waiting on a approval? Why it matters is this is money, y'all, that is on hold. Like, it's work that's already been done, but it hasn't generated any type of revenue for you. And so large pending balances indicate a bottleneck, maybe in coding, authorizations, or providing signatures. Tracking pending charges help leadership see where the process is breaking down. So if you run your charge reports monthly, if you run these reports monthly, you can see. And sometimes if you have the staff in your office, if you can run them every 2 weeks, it will help you with a consistent flow of less denials and revenue generating through your agencies. A denial trend report, like denial reports show why payers are rejecting the claims, incorrect codes, missing authorizations, non-covered service, late filing. This matters because denials are lost or delayed revenue or extra work for staff. So if these are lost or denied delayed revenue, that means your staff you've already paid them for it, so now they have to go back and try to figure it out. Now guess what, you're paying them again for something you've already done. So the same mistakes get repeated if no one is looking at these patterns. And so denial trends often point directly to documentation issues: wrong code, no medical necessity, missing and stop times. How to use these reports. Run denial reports by the payer, by the worker, denial code, clinicians, or the location. You can break those reports down, run them that way, and See which one works best for you and it helps. Look for the patterns. Aetna denying H2017 due to missing modifier. Healthy Blue denying IOP for missing prior authorization. These are the things that you have to look for. Or multiple PSR claims denied for incomplete diagnosis. Turn those patterns into targeted trainings. This month, we're fixing H217 denials. Checklists or EHR validators to prevent the errors at the front end. And then the next is regular review, productivity and reimbursement matrix tied to documentation. So documentation versus revenue, not just how many sessions. What this means is productivity is usually how many billable hours, units the clinicians complete. But high productivity doesn't matter if the notes are poor and the claims are denied. You can have 100 and 200, 300 clients. It doesn't matter how many clients you have. If the documentation is poor and the denials are there, you defeat the purpose of seeing these clients, because guess what? No, there's no revenue coming in. So a clinician can show 30 hours a week on a schedule, but if notes are late, documentation don't support medical necessity, or claims getting denied, the agency is losing money and increasing a risk. Looking at number of sessions can hide documentation problems. I'm gonna say that again. Looking only at number of sessions, that can only hide the documentation problems that you have. So you can use matrix like pair productivity matrix, clean claim rate, claims accepted on the first submission, denial rate per clinician or the program, and average days from services to sign encounter. Like, you can use all those things in your EHR system as data to help improve what you're missing. Some practical matrix to review monthly, quarterly, like the percentage of encounters of signed notes within the 24-48 hours. When you log into Checkpoint, you have those various matrix. It gives you those things. The percentage of notes returned for correction. It's something that you can keep up with. How many notes are you sending back for correction monthly? Denials related to medical necessity or insufficient documentation. Excuse me. And missing or incorrect time based on those codes are all things of that. And so using dashboards to track clinician specific patterns and areas of training. Excuse me. Dashboards equal visual snapshots of key matrix, usually pulled directly from your EHR or billing system. You have open note counts. You can do your open note counts, days since your last note was signed, denial rates, the average time, and units billed versus what's denied. Why does your dashboard help? Real-time visibility. Your staff can see their status without waiting for monthly reports. Each one of your staff, in Checkpoint or whatever your EHR system has these right at their fingertips, where they can see where they're lacking at. They can see how long it took them to sign their notes, how long it was before they seen the client. Those things are all trackable things that we want to use for that. And so pulling all this together and leveraging analytics and reporting, finding leaks in the revenue pipeline, open encounters, pending charges, repeated denials. 2 is connecting documentation quality to financial health. Productivity only counts if the claims get paid. And supporting staff with clear data. Dashboards and reports show exactly where training, reminders, or system tweaks are needed. You can frame it for your staff by saying we're using data not to punish, but to protect our agency, keep paychecks coming, and make sure we're paid for the real work you've already done, already do. So those are some of the things in leveraging analytics and reporting. So training and ongoing support. Instead of only doing big training during orientation or once a year, staff get targeted help right when they're stuck in the EHR system. I think that is really, really important. So if you take the time to help your staff when they're trying to put in a note right then, so like when clinicians are confused in the moment, they'll either click random things to get past the screen or walk away, finish later, which also means incomplete or late notes. And again, it also means memory loss, because if you're not doing your note right then, you're losing some of the things that you did there. So, and it saves on denials, a quick teaching moment. Just use it all as a quick teaching moment. Just in the time training helps them to do a task correctly on the spot, which protects documentation, billing and compliance. Provide just in time EHR training, standardized workflows to reduce confusion, offer short refresher sessions on new billing rules and EHR updates, and encourage clinicians to personalize templates and shortcuts to speedy accuracy. Um, if everyone follows the basic steps for the key process, and I feel like that's one thing that you in your agency, like if everybody followed the same thing, instead of every person doing their own way, it will help eliminate billing denials. Inconsistent workflow equals inconsistent documentation equals inconsistent billing. Billing and QA staff waste time chasing down what should have been done from the start. So new hires get confused. New hires get confused when different clinicians tell them something different. And I think this is a major thing that happens from agency to agency, from the various ones that I've worked for before. Like, this is a major issue that I hear all the time is, oh, well, this person told me to do it this way. Well, this person told me to do it this way, and this person told me this way. So if you have three different people training and three different people doing it a different way, then it's going to frustrate your clinician, one, and then two, it's going to not be able. They're not going to be able to do a great note. And so if everyone follows the same flow, regardless of which office you're in, best practice. Map workflows for each major service, CPS, CPSR, ILP, therapy, med management. Put those things into training. New hire training, make a quick reference guide so they can go back. Even in Checkpoint, they have small videos that you can go and look if you never went and looked there. There are videos of various things of how to do in Checkpoint. One is billing. So if you go in and watch those videos and you kind of mimic what they have with your own agency, it will definitely eliminate some of the denials. Train your supervisors to coach the workflow when you're not available. And then offer short refresher sessions on billing. Instead of long annual trainings, you provide small focused refreshers, 10-20 minutes on specific billing EHR topics. Doesn't have to be that long. And this matters because billing rules, payer requirements, and EHR features change often. Staff forget details that they learned months ago or even when they were annually trained. Short refreshers keep the information alive for them without overwhelming staff and killing the productivity. And so things that you can look for in your agency is monthly or quarterly sessions, 10 to 15 minute in-staff meetings or Zoom topics like top 5 reasons we get denial on ILP claims, or how to document time correctly for CPST, or new Medicaid modifier rules starting this month. Like micro learning, post one short tip on your EHR screen, or email them. Again, depending on your EHR system, whatever EHR system you use, just find those functions and see what you can do to help your staff out. And then encourage clinicians to personalize templates and shortcuts. Within standardized templates, clinicians can create their own smart phrases, shortcuts, and favorite layouts to speed up documentation while still meeting requirements. And one of the things they can do is, like, for a CPST worker, has phrases like, or a PSR, skills practiced, and you list out your skills. Client's ability today was homework, next step, and you list those things. Emphasize shortcuts or starting points, not final notes. Staff must always update the time, date, client-specific content, and progress. The best practice is to share approved examples of good templates for your staff. Like, if you don't teach them good note practicing, then you will have denials. It will raise red flags. This is where the recoupments come in. And how this all ties together is helping them in the moment in the training. Make sure everyone follows the same basic steps, standard workflows. Keep knowledge fresh and current. And let clinicians work smarter, not harder. And you'll end up with better documentation, fewer billing errors and denials, faster reimbursements, and less frustrations for clinical and billing staff. Those are the things that you can focus on when you're training. Like, when you're training your staff to use the EHR system, you always have to keep in mind that the way I train them is the way they're going to document, and the way they document is the way that my revenue comes in. So if you train poor, you document poor, your revenue comes in poor. Remember that. Patient-facing billing improvements. Use portals for estimate statements, payments, improve accuracy of coding to reduce callbacks and confusion. Encourage capturing social determinants or valued-based care elements that support reimbursement programs. And this is more so for those who are in MHR, who some people do private pay. And so sometimes you want to make sure that those your statements and billing things are in has some type of accuracy, well, complete accuracy. In Checkpoint or in your EHR system, if you have a patient portal, I encourage you to get with your rep and get that online billing feature turned on, because one, at the intake, it can help you. Once your clinicians, your licensed staff doing assessments, treatment plans, and things like that, assessments and treatment plan in the client portal, you can send it to them for review. They can sign off on their treatment plan in that client portal. And so you can communicate back and forth, and you can also build a relationship with your client in that patient portal, and it builds trust with them. And so if something was to go wrong with their statements or have any issues, then in that patient portal they can see. And this is kind of mainly for my private pay people. Make sure that you build these things in with your patients, your clients. Make sure that their statements are always accurate, and it helps with feedback and cuts down confusion. And encourage capturing social determinants or value-based care elements that support reimbursement. And so we have to get into the habit of listing things like, if during session, if they're having issues with housing, food, transportation, safety, education that impacts your client's mental health and ability to stay in treatment, you need to make sure that those things are in those sessions, because again, you want to make sure that you're billing for those things. So this point is about training clinicians to document those factors clearly and consistently in their record. Because again, when it comes back to audit purposes and recoupments and things, these are the things that you want to make sure that you put in your notes, in their notes, in their sessions, to make sure that, hey, my staff is doing excellent notes. I'm not paying back any type of money. So you need to make sure that those things are in here. And I'm moving kind of fast because my time is almost up. Compliance and risk management. Emphasize correct coding to avoid audits or compliance issues. Use EHR tools to ensure documentation meets payer and regulatory standards, and regular reviews of coding patterns to ensure alignment with guidelines. And so when it comes to emphasizing correct coding, what it really means is correct coding is more than picking a code that seems close. It's making sure that the CPT codes, modifiers, and diagnoses are accurately reflect the service provided, the time and intensity, the clinical need and medical necessity. When codes and documentations don't match, it looks to the payers like upcoding, billing for more intense or longer services than what was done. Unbundling, meaning billing parts separately that should have been billed together, or simply poor documentation, which raises red flags for audits. And this all matters within your organization because it's a financial risk, which makes incorrect financial risk comes from incorrect coding, can lead to recoupments, penalties, and being required to pay the money back. Your program is at risk. Repeated issues can lead to providers being placed on pre-payment review or even removed from payer panel. And I'm telling you, prepayment review is not a good thing, because you literally have to send your notes in, send the staff, the clinician notes in, let them get reviewed first. If they feel like those notes met, then you get paid. That is a hassle that you do not want to be your agency to have to deal with. And licensure risk. In extreme cases, patterns of fraudulent or negligent billing can trigger licensure or board concerns. And so you always want to make sure that your staff, your clinicians are billing within their scope and making sure that they're doing always doing best practice. How can you incorporate these things into your practice is one, train clinicians on what each code requires, time thresholds, documentation elements, and complexity. Use code cheat sheet. Give your staff a cheat sheet. If they're only supposed to do CPST and the codes that's on your CPST, if they're using anything outside of that, then they know that something is wrong within the system. So use cheat sheets for quick references, guides for CPST, PSR, therapy, medication management, IOP, etc. And encourage your staff to ask. If an auditor read only this note, would they understand why you build this code? And so always ask your staff that. And sometimes you have to ask them, reread your note, and as if you were an auditor, and tell me what you feel is, if this note is correct. Coding isn't just a billing decision, it's a compliance decision. Every time we select a code, we're telling the payer, this is exactly what we did for this amount of time, for this reason. If the note and the code don't match, That's where audits, recoupments, and risk start. So please be mindful. Like, again, you have to train your staff on this. And the second point on this one is when you're using your EHR tools to ensure documentation meets payer standards, required field checks. You can't close a note without a diagnosis in a tool. Of course, we talked about that. Templates built around payer rules, section goals, intervention, client responses, and prompts or alerts. Treatment plan is expired, no diagnosis is attached. If you're, that's another thing. When the authorization expires and you don't put a new treatment plan in or goes in for them, your staff can't use those old ones because guess what? The payer is gonna when it comes to an audit, they're going to review their treatment plans. And if that's not the current treatment plan that they got on file for that specific date, then they're gonna want their money back. So you have to remember these tools that are in Checkpoint or in the EHR system, they're hardwired compliance into your workflow. Like they're here to help you. You're not relying solely on memory. You're relying on this hardware wire compliance that's imported into your EHR system. It reduces human error because people forget, systems don't. Keep staff aligned with changing rules. When templates prompts are updated, everyone benefits. And build an audit ready record. When notes consistently contain all required elements, audits are less stressful for you. So my thing to my staff is if you do it right the first time, you don't have to worry about everything else to follow because everything else will follow in line. How to put this in practice. Show clinicians how these tools help them, not just this is another box you have to check. Like go through Checkpoint, go through your EHR system that you're using. Actually train your people step by step on this thing. Don't just say this is how you put the session in and be done with it, because if they know how things work here, where they can go find things, they will better understand the importance of their note. And regular reviews of coding patterns to ensure alignment with guidelines. This is about stepping back and looking at the bigger picture. Are some providers always billing the highest code? Are there services that are almost never used, even though our population would justify them? Or are certain codes tied to more denials than others? Those are things that you need to look for when you're looking for effective billing. You're looking for patterns, not judging a single note. Early warning systems are unusual patterns that can be indicate a misunderstanding, poor training, or risky habits. Fairness and consistency ensures clinicians in the same role are billing in similar defensible ways. Continuous improvement, denial trends and coding patterns to where you need more training or better workflow. And lastly, how to put all these things into your practice. Run monthly or quarterly reports by provider, program, and code type. Use the data to coach, not punish. We're seeing a lot of denials on this one code. Let's walk through what the documentation needs to look like. And build this into your QI or compliance committee agenda. Coding denial reviews is a standing item. Like compliance isn't just about catching people doing something wrong. It's about noticing patterns early and giving support. When we regularly review coding and denial data, we can fix a misunderstanding with one training instead of dealing with hundreds of risky claims. So you rather train your staff on something now than thousands of dollars later. And how to tie all this together for your staff. Correct coding keeps us out of trouble and makes sure we're billing honestly and accurate. EHR compliance tools help us to meet payer and regulatory requirements without memorizing every rule. And then regular pattern reviews allow us to course correct early, protect revenue, and reduce risk of the agency and each provider. Um, Compliance and risk management aren't just the billing department's job. Every note you write, every code you select, every template that they select is a part of protecting their license, the company's license, our agency, our clients, access to service. When we code correctly, use the EHR tools, and learn from our data, we're not just avoiding trouble, we're building a stable, trustworthy organization that payers and families can really rely on. And so you have to remember that documentation is the key to less denials. The overall goal for billing should be documentation should naturally flow into billing. Ensure clinicians spend more time with patients, clients, and less on administrative work, and be a reliable, transparent billing system for the entire practice. And so overall, you want to make sure that you train well to begin with, so that you don't have these issues later on and your clinicians don't have to worry about these things. So again, thank you. I appreciate you all for taking the time to watch this video. My name is Shawanda Martin. I am a independent consultant. You can get my information from Katie. I do assist and help agencies with their needs. I'm currently only working with individuals who currently work with Checkpoint at the moment. Their billing system is Checkpoint. And so, yes, my email is sreneeconsultant83@gmail.com. You can reach me via their LinkedIn at Shawanda Martin as well. And I appreciate this time from you guys watching this, and I appreciate Checkpoint for this opportunity.